Thank you, Mario. I have been asked again to review this in 20 minutes, what it's quite impossible, and we should be glad actually that it's quite impossible, because this means that several new drugs are coming in the arena of clinical development in colorectal cancer. And basically, one way to address this is to follow the 10 characteristics that Hanahan and Weber describe on the malignant phenotype. And certainly this is, as you know, this is an excellent publication. And what we are going to focus today are in 5 different aspects where we have drugs that are in clinical development. So basically, drugs that target the proliferative pathways, drugs that target some of the properties of the instability of the genome and some mutations. We are briefly review some of the drugs that are targeting the multiple angiogenesis process. And finally, we are going to be addressing also some drugs that target invasion and the metastatic process, as well as some drugs that are trying to restore the immune function of the human being. So definitely more properties that we used to describe in the previous presentations. So this is the outline. I'm going to talk a little bit on how we target beyond EGFR with other receptor kinases, also the Wind and beta-catenin pathway, some very challenging data that was presented at ASCO from one of these particular compounds. Also, as mentioned, some drugs targeting the angiogenesis process beside BGF and BGFR, and finally, these immune activating agents. So beyond EGFR, we know that we have in the clinics 2 monoclonal antibodies, cetuximab, panitumumab, targeting the ectodomain. Also, seminal work and most of the work also presented here on how potential biomarkers like not only KRAS well established, but now NRAS, BRAF, and some other mutations in PIK3K may derive and may provide us information which is the real population of patients that benefit from the treatment. So the first concept is try to get more efficient monoclonal antibodies targeting the epidermal growth factor receptor. And actually, you have here some of them, GA201, Symphogen 04, and the glyco-optimized cetuximab called cetuximab. I'm going to talk a little bit on GA201. This is a glycoengineered monoclonal antibody, and basically the difference between an antibody like cetuximab and this is that there is a change in the residue of the Fc portion with non-fucosylated forms in this setting. And actually what actually produces is a tight binding with the Fc gamma receptor of the natural killer cells and lymphocytes, and at the end, this enhances ADCC. So basically, this has been shown in some preclinical models. You can see here the property of induction of ADCC with cetuximab, with panitumumab, and with this compound. And as you can see, much more induction of ADCC. This compound has been evaluated in a phase 1 study showing responses in patients with previously treated with EGFR inhibitors, and a randomized phase 2 study that has been developed in patients with refractory metastatic colorectal cancer is being evaluated at this time. The recruitment is completed, and we will have the data in the next months, I hope. The second concept, is to produce monoclonal antibodies that are mixture of different monoclonal antibodies that target different epitopes of the receptor. And this is one concept that actually was developed by Yossi Yarden and his group several years ago, by the targeting of the receptor with different monoclonal antibodies, we induce tetramers that have a molecular weight around 500 kilodaltons, and this induces actually down regulation of the receptor because the degradation of this complex is much higher than with one single monoclonal antibody. Again, some preclinical models also showing more activity for a compound like this, Symphogen, and this compound is also being evaluated in patients with refractory metastatic colorectal cancer, KRAS wild type, that have been previously treated with other antibodies, either cetuximab or panitumumab, just to demonstrate the proof of concept of activity in this setting. The second concept is to target other members of the HER family. And actually here we have a cross relation very well defined between the epidermal growth factor receptor, HER1 and HER3. And in here, also we know that HER3 may play a potential role in proliferation of some of the colorectal cancer models, but actually as a mechanism of secondary resistance of some EGFR inhibitors. This is well demonstrated in non-small cell lung cancer, not so well demonstrated in colorectal cancer, but some studies are actually evaluating some compounds in this setting. And you have here a slide that summarizes some of these compounds. I'm going to focus only on the Genentech compound, this MEHD7945A, because this compound is a dual monoclonal antibody that targets at the same time HER1 and HER3. And this compound was evaluated in a phase 1 study, also with some activity in patients with colorectal cancer, EGFR wild type, previously treated with monoclonal antibodies. And now there is an ongoing clinical trial in the second-line setting evaluating the combination of FOLFIRI with this dual monoclonal antibody targeting HER1 and HER3 compared with FOLFIRI and cetuximab. Also, we are aware of the HER2 new overexpressing population in patients with colorectal cancer. If we focus on the quadruple negative population, this means KRAS wild type, BRAF wild type, NRAS wild type, and PIK3K wild type, this population may be up as high as 30% of the patients. So an Italian study actually is trying to reproduce first of all, the frequency of HER2-neu amplification and overexpression in colorectal cancer, but also they are treating patients with the combination of trastuzumab and lapatinib or trastuzumab and pertuzumab, trying to demonstrate that this population actually is sensitive to this dual blockage of HER1 and HER2. Another concept is to add to epidermal growth factor receptor monoclonal antibodies, other monoclonal antibodies that target organ receptors that have cross-talk with this pathway. And probably the most important one, as it was mentioned in the slides by Paolo Comoglio on Wednesday, is c-Met. c-Met by itself, it's expressed in colorectal cancer in a wide range. We don't know really the level of expression and what actually does mean, but we know that the c-Met pathway is really important for proliferation and also for some other processes like migration and angiogenesis. Also, we know that c-Met gets amplified in patients that have been previously treated with cetuximab and panitumumab, and this has been very recently presented by the group of Alberto Bardelli. These are one of his slides, and clearly showing that patients that before being treated with panitumumab, in this case, did not have any amplification on c-Met, at the time that these patients progress after treatment with panitumumab, they had amplifications on this gene. And this was evaluated not only by amplicons for MET, but also looking at the gene copy number. And this is a slide that clearly shows patients before being treated with panitumumab without c-Met amplification, and once they are treated with panitumumab, you can see that these tumors bear c-Met amplification. So MET amplification is one of the multiple mechanisms of escape to EGFR inhibition. Also, from a clinical perspective, in order to inhibit the HGF c-Met pathway, we have several ways to do that. Basically, monoclonal antibodies that can target the ligand, HGF in this case, also monoclonal antibodies that can target the ectodomain of the receptor, like the METMAP or natumumab, and finally, kinase inhibitors that target the pocket domain. The data that we have so far in colorectal cancer comes from a small randomized phase 2 study of the combination of panitumumab and rilotumumab. This was a study that actually evaluated another combination, also panitumumab with ganitumumab. Basically, for the combination of panitumumab and rilotumumab, you can see that it was suggested a trend for a benefit in those patients that receive the combination of panitumumab and rilotumumab, at least for progression-free survival. I'm sorry because the slides are not really very clear, but when we look at the data, especially comparing the expression of MET in the primary tumor samples, actually those patients that had high expression of MET seem to be those that benefit more of the treatment. Obviously, this is a concept that has been suggested in a randomized phase 2 study. The good news for that is that now several trials are being evaluated in the setting of the second line or third line in patients that are KRAS wild type, BRAF wild type, and RAS wild type, addressing the combination of cetuximab or panitumumab with other antibodies inhibiting the c-MET pathway. And the fourth concept actually relates to some of the properties that Sabine Tejpar and other presenters have been mentioning before on how the downstream effector mutations that we know this pathway has in several tumors can be targeted with rational-based combinations. Sabine alluded before on one of the aspects that this work on the Cancer Genome Atlas Network introduced on the presence of several mutations in the different populations in patients with colorectal cancer, either hypermutated or non-hypermutated. But we have to think that even the non-hypermutated population in colorectal cancer is highly hypermutated compared to other tumors, other solid tumors. So, for example, for BRAF, this is well established, accounts for 4 to 5% of the latest stage population. And we have been aware on the data coming from several different trials that in the first line, in the second line, and even in the third line setting, it does seem that EGFR inhibitors do not benefit this population. So very clearly, this is a population of patients, a niche, where we need other drugs and combinations that could be effective in this setting. Actually, you know the data also coming from the work that our colleagues in the melanoma field have shown on the BGFR inhibition, on the BRAF inhibition for the V600 mutations with vemurafenib and other BRAF inhibitors, showing a dramatic response in this setting, but this was not the case in colorectal cancer, at least with 2 different BRAF inhibitors when they were administered as single agents. And thanks to the work of the group of René Verdaersen and Jeff Engelman, actually we have information on which is one of the potential mechanisms of escape when these tumors that are BRAF mutated are treated with a potent BRAF inhibitor like vemurafenib, thanks to the upregulation of some tyrosine kinase receptors, especially EGFR. And thanks to this work, actually, the same authors were able to show that the combination of a EGFR inhibitor plus a BRAF inhibitor actually was really active in these tumor models. And this concept is at least being explored in 3 different clinical trials, combining EGFR inhibitors with either BRAF inhibitors, MEK inhibitors, or the combinations of both, or even the combinations of a BRAF inhibitor and an EGFR inhibitor with a PI3K inhibitor. So basically, in the next years, we are going to have data. What we know so far is that in some of these studies, actually some patients are really benefiting, having dramatic responses to this combination. So this is a concept that I'm completely sure that it's going to work. What about for the RAS population? Actually, I'm talking now about RAS, never more KRAS. So the RAS population actually accounts for around 45% of the patients that is mutated in colorectal cancer. And here, obviously, we know that these compounds that do not work in this setting, but also there is a hint for trying to address whether a combination of a receptor kinase inhibitor like cetuximab or panitumumab in combination with a MEK inhibitor may be of interest in this particular population. Actually, there is preclinical work coming from different sites that this approach could be beneficial, at least in these preclinical models. Also, we have to think on the disease on a very plastic way, and just to this slide to make the point that patients that are considered KRAS wild type from the early beginning, when they are treated with some EGFR inhibitors, so the tumor is put under pressure for selection of very marginal clones. Actually, some of these tumors are going to deal with KRAS mutations over time. And this has been very nicely presented by several groups, making the point that from the early beginning, we are going to have different populations of cells. One of them is going to be probably the most important one, but by selection under pressure of the treatment, when it is targeted to some particular clones, we are going to be able to expand some other clones. So we have to think in a way of treating the disease in a dynamic way and trying to address which is the proportion of clones that may be representative of the most frequent cell populations in each particular setting. Moving to the second concept, the Wnt beta-catenin pathway. This is an important concept, especially in colorectal cancer. And actually, this is a pathway that has a dual function. So in one side, it may promote a quiescent state in the cells that do not need to proliferate, but also in the other side, the activation of this pathway may promote proliferation and migration. The important thing in colorectal cancer is that this pathway is almost universally dysregulated, because most of the patients in colorectal cancer have either APC mutations or beta-catenin mutations, and even ATSIM mutations. And actually, these mutations are present from an early point of the development of the adenomas. So basically, several compounds are being introduced now in the clinical setting, trying to block the Wnt beta-catenin pathway at different levels. But if you remind the problem that we have in this pathway, most of the mutations and aberrations are going to be here with APC and beta-catenin, not in the receptor. So it's very important that we focus on compounds in colorectal cancer that are able to target and to abrogate the signal downstream from beta-catenin. And actually, one of these compounds was presented this year at the ASCO meeting by Antoni El-Kouheri from the group of Dr. Lenz. Basically, this is a compound that is able to inhibit the binding of beta-catenin to CBP before this complex promotes the transcription process. And actually, there was activity in patients with colorectal cancer in this particular phase 1 study, and as you can see in the summary slide of this study, some clinical trials are being conducted now in patients with colorectal cancer in combination with standard chemotherapy. And even a randomized phase 2 study has yet been planned in this setting. A few words on other ways to target the angiogenesis process. And again, you have seen, probably most of you, this slide. This is a complex phenomena, angiogenesis. So we have not to focus only on BGF and the BGF pathway, but also to other important pathways like FGFR, inflammation, angiopoietins and Tie2 receptor, the TNF-alpha, and also the integrins that play an important role at different steps in this angiogenesis process. I'm going to talk about two compounds. We have mentioned that integrins are really critical to promote angiogenesis, both in the normal phenotype, but especially in the malignant phenotype. And especially the alpha-beta integrins are really important in promoting this angiogenesis phenotype, as well as tumor cell survival and tumor progression. And actually, there are several strategies now blocking either in a very specific way, selective integrins like alpha-V beta-3, but also some other strategies are including the whole complex of alpha-beta integrins, because it's believed that all they are important at several steps in this angiogenesis process. This is one of these compounds. This is a monoclonal antibody called DI1788. It's an IgG2 monoclonal antibody that actually is able to bind to all the different alpha-beta integrins. And coming the data from phase 1 with some suggested activity in colorectal cancer, actually this compound is being evaluated at this time point in combination with irinotecan and cetuximab in the second-line setting in the population of patients that are KRAS wild type. The second compound that I want to discuss today is an antibody directed to the EGFR7 protein. This is a protein that actually is fundamental to stabilize the network that is induced outside the endothelial cells and the pericytes. There is preclinical work showing that a monoclonal antibody directed to EGFR7 is actually synergistic with monoclonal antibodies targeting the BGF ligand. This compound, again, is being evaluated in patients with colorectal cancer, first line, in combination with FOLFOX and bevacizumab in a randomized setting. And finally, 3 slides on what the field of immune activation may produce in some solid tumors. You are aware that the inhibition of the cellular function by different receptors and ligands that activate the receptors like PD-L1 and the receptor PD-1 is really important, but this is not the single receptor and ligand that actually are able to abrogate this immune function. As you can see in this slide, several other receptors and ligands are being targeted now, at least in a preclinical model, in preclinical models. But as you can see in this other slide, and as it has been presented at the recent ASCO meeting, several monoclonal antibodies have shown seminal, I would say, outstanding effects in patients at least with melanoma, renal cell carcinoma, and in some patients with non-small cell lung cancer. Actually, I want to point your attention on these 3 monoclonal antibodies that are in clinical development, especially on this Genentech compound. This is a human IgG1 monoclonal antibody directed to the ligand, to the PD-L1. And in this particular compound, beside the phase 3 clinical trials in the selected tumor types that I mentioned before, it's being evaluated in other tumor types, including gastrointestinal malignancies, as you can see in the next slide, I guess. Yeah. So basically, what in this trial has been done is try to select the patients with other tumors, adenocarcinomas, that express the PD-L1. So not all the solid tumors actually have this abrogation phenomena of PD-L1 inducing the PD-1 receptor. But for those tumors that actually have expression of PD-L1, you can see in this very preliminary setting, so this is a phase 1 study, and you can see that there are patients with colorectal cancer and gastric cancer that actually achieve activity and partial responses in this setting. This is the preliminary data. Now, this compound is being expanded in more patients with colorectal cancer, gastric cancer, provided that they express PD-L1. And the activity that is being seen is really very nice. So probably this type of compounds are going to be developed also in some patients with gastrointestinal malignancies. So this is my final slide. Thank you for your attention.